Good morning, everybody. That was John Fogerty from the famous Creedence Clearwater Revival singing a little song on his own, Fortunate Son. Very, very popular song. This is Dr. Minarcik, and this is kind of a emotional and historic day for me. This is not only our 42nd session in Global Medical School Pathology, but it's our 23rd session here with the Caguanese Palos Gallinas de Palo. It's also our final session in Caguas, Puerto Rico, and in a couple days from now, I may still be giving it from my office, but technically this is my last presentation. We had a little technical problem with the monitor, but Mario, our ace engineer, just fixed it. I don't know how. If he explained it to me, I probably wouldn't understand anyway. It's 8 o'clock here in Caguas. It's February 12th. It's 2 days before Valentine's Day. And the music that I picked today, you know, with possibly the exception of the first song, is very, very smooth, quiet, thoughtful music because of this relatively emotional day I'm having today. We could make a couple announcements now that a few more iguanas have strolled in. Probably the first thing we should do, though, is do our little audio-visual test. The first question is, can you hear me? And the second question is, did you hear the music well? Okay. And the third question is not a yes-no question. It's a fill in the blanks. I see 3 blank on my screen. Good. Owlets or owls. So we're cooking today and we're ready to go. Like I said, this is my final session. I'm a little bit emotional. I don't want to make speeches and start crying and stuff like that. But I will say, hopefully, I haven't rehearsed this. Maybe I should have. But, you know, we all look for respect in our life. Some people become a doctor to get respect. Everybody thinks they don't get enough respect. As you get older, you realize that that is a quest that is not worth it. I would rather not get any respect at all as long as I could learn how to give respect. And I will admit, I have been treated like a king over here, not only by the students, but by everybody possible, administration. I felt like I was a rock star in many respects. And it was something I have a hard time dealing with because I know I'm not. But what I learned the most in Puerto Rico, the culture, is that you are a culture of giving respect. And I've learned a lot on how to give respect, and I put away a lot of my arrogance and, being a Chicago wise ass. And that's, if somebody says, what is the number one thing you learned in Puerto Rico, I would not say how to catch iguanas. I would say I learned a lot of respect here, and I want to thank you for it. And that's all I'm going to say. This is our last day. This is also our final session in central nervous system, too. Let me go into a little explanation of what we're going to do today. We were a little bit rushed on CNS-I, because Neil over there made me real nervous. He says, Dr. Mejias is coming in, so probably the last few minutes I had to rush through. I don't like that, but we're not going to rush today because I know we have basically unlimited time. And even though I could probably do this in a couple hours, maybe a little bit longer, we're going to take our time and finish up. Now, the problem is, because this is our last session, we will not have a review session. However, if you remember, we've gone through a little bit of a progression here between having no review, between having a review kind of haphazardly plugged into the PowerPoints, and between having a review last time, which I think was ideal, it was plugged into the lecture notes verbatim, if you remember that. So the review that we're going to have now is to give you what I would have normally plugged into the lecture notes. And now I'm going to go over it. I've already chosen the questions. As always, when the first time I saw them, I was in a panic and I was angry and I was thinking of getting my lawyer, suing the USMLE. Now, when I read them a little bit more carefully, it's a little bit better now. In fact, quite a bit better. So you're going to do well on this exam as well, as far as I'm concerned. I chose 80 questions, and I don't know how many everybody else chose, but I would imagine 80 is going to be the majority of them. I guess I did have a little survey to ask everybody here is, do you feel you're doing well on the exams when we do the intense reviews focused around the topics? I've talked to a few students after the last one, and they were happy. I got the impression that was a consensus, too. Okay, part of your CNS experience is I. I don't do I. I do everything except I. My son does I. My son is a world-famous ophthalmologist and retinal surgeon. He always does the last session. I called him the other day and I says, you want to do I live? He says, well, Dad, I got to do a lot of surgery in the morning. So he made a really good movie last year, or maybe it was the year before. So I want to leave it to you voluntarily when you know you're responsible for I as part of the curriculum here, is to just watch his movie. It's not like me, 2 hours. It's only 1 hour, and it's spectacular. It was rated like 10 times higher than mine. And, of course, I didn't like that, but how about if we start going now? Oh, and when we do the Thursday session, technically I'll be not working here anymore, but I'll do the Thursday session for only the buzzards. Of course, you're welcome to come. It's going to be something that we have to sorely catch up on. It's going to be a 100% lab. We didn't do a lab for skin or musculoskeletal, and we did not do a histopathology lab for CNS. Now, by the nature of the questions that you're asked, you might not think that the labs are very important, but I got people there that really, really want to see the diseases, and pathology residents too. So I want to make sure that Thursday at our usual time here, probably in my office or maybe at home, I'll be doing another session. And of course, you have the option for the iMovie anytime because it's on my website. Another thing that they've asked me to talk to this big international group of pathologists that gives webinars on GoPath as well. So I'll be doing a webinar Saturday after I get home. It's probably not something that's going to be on your exam, but if there's anybody here that really wanted to wonder why I do this, how I do it, or the exact technical details of everything I go through, it'll be on that webinar. You don't have to be there personally on Saturday. We'll have that as a movie as well. Okay, I think we're ready to rock and roll, and probably somebody, I don't know, we're probably having a fight here between Mario and Jose. I think Jose's going to win because he's bigger. So let's go and look at number one. Is it down there somewhere? You want me to start it up? Here, I'll get it. I don't think I started it up, so how about if we start it up now? CNN is really rocks. It's really terrific. I like it so much. I think this is kind of where we said we would start off with the second big 2-hour session on CNS. If you remember in the first session, we dealt with a lot of the common things like strokes and infections, all the classical kind of things. Do you remember how every time we started out a chapter, we would start out with something like degenerative, inflammatory, neoplastic, you know, the ultimate classifications of all diseases of all systems. Very often we kind of neglected the so-called degenerative portion. Well, today we're probably going to be spending almost the entire 2 hours on things related to CNS degeneration, a lot of the more exotic degenerative diseases. And if you look at the next group of questions here, which is going to be the last 6 questions, we dealt with the first 7 questions the other day. That's past history. We're going to be saying, what are these are all basically, except for maybe tumors, sort of degenerative diseases. Degenerative functions, degenerative pathophysiology of the central nervous system. What are these mysterious prion degenerative diseases, these fatal diseases that are caused by bugs that don't have DNA? Woo, that's weird. What are the pattern of the CNS demyelinating diseases? Now, we told you a million times already that demyelination is a totally nonspecific response to injury, just like gliosis and edema is. But there are also specific demyelinating or demyelinating diseases, generally grouped under the big overall name of multiple sclerosis, although there's multiple sclerosis variants too. Very often the term demyelination is kind of synonymous with the concept of multiple sclerosis. They'll be talking about the classical degenerating diseases, the dementias. I really did not want to use this term, but very often you just hear somebody say, you know, this person lost their marbles, okay? That's generally dementias. But then if you go down from the cortex to the basal ganglia, to the cerebellum and midbrain, all the way down into the spinal cord, there are other classical patterns of degeneration as well. And every one of those 4 areas has one single word that describes the degeneration that's going on. In the cortex, it's called dementia. In the basal ganglia, it's called Parkinsonism. In the cerebellum, it's called ataxia. And of course, further down the spinal cord with the tracts and the neurons, it might be called motor neuron diseases. So those are basically the 4 things we're going to be talking about and try to sort them out. Finally, we're going to go into this category of metabolic diseases. Big category, a lot of genetics here. I'm not going to throw them all at you, but they're almost all genetic. Then we're talking about the common metabolic toxic things. It's not just alcohol that poisons your brain. There's probably about 8 or 12 other common ones, most of which you already know about. And finally, probably the second hour, we're going to be talking about what pathologists could probably talk about for 10 hours, and those are tumors. And I promise not to give you a whole bunch of weird things which don't matter. We're going to go into the basics. You know, the tumors of astrocytes, the tumors of oligodendrocytes, the tumors of ependymal cells, and also tumors of something which normally don't multiply. And those are neurons, with tumors of precursors of neurons. Those are basically the categories of neoplastic diseases. So what's next? Prion diseases. Okay, prion stands for, I always call them prion, but when I look at the erudite professors from Harvard, they usually say prions. I don't know what you would want to call it. Probably either way is acceptable. Prion stands for proteinaceous infected particle. And isn't that interesting? Because you don't normally think of proteins as infecting. You usually think of things like viruses and bacteria as infecting. So how could a protein infect? Well, we're going to try to get into that. The generic term in humans for the family of prion or prion diseases is called Creutzfeldt-Jakob disease. I've also seen this as Jakob-Creutzfeldt disease. I don't know why it's kind of switched, but I have a theory, because if you call it Jakob-Creutzfeldt, then you have to say JC. But if you call it Creutzfeldt-Jakob, then you have to say CJ. And if you know, already remember, there was a virus called the JC virus. So maybe it's done that way to differentiate it from the specific demyelinating viral disease by the JC polyoma virus. Take a look at some of these terms. They are all prion diseases, some in humans, some in animals. Another extremely weird prion disease, which I'm going to try to pronounce, Gerstmann, Straussler, Schenker syndrome, GSS. I guess if you wanted to look really, really cool over at a neuro conference, just go up to some of those Harvard-trained guys and say, oh, I saw a case of GSS the other day. And they'll go, wow, you know, you must be from Yale, you know. So it's also like Jakob-Creutzfeldt, very rare, maybe, you know, 1 in a million, okay, not very often. Familial as well. Fatal familial insomnia, another syndrome, also very rare. As you might guess, it's a prion disease, and it might have insomnia as a big part of its CCPP, so to speak. These are basically all fatal diseases. And furthermore, there's no treatment either. So remember that. A lot of research, but no treatment, and they're all fatal. The cannibals, I believe in Papua New Guinea, I don't know if they're still there, but they used to get it too, and they used to get it from, you know, eating the brains of their enemies, that cannibalism. So you could probably call it a cannibal disease. That was called Kuru, a disease in sheep and goats. Scrapie is another prion disease, a disease in minks, which are transmissible. And remember, these are all transmissible. They are transmissible proteins that cause the infection, called mink transmissible encephalopathy.
Like how exactly are they transmitted? Like, can it be like you sputum or?
Yes. I'll tell you a really good example in a minute. A chronic wasting disease in deer and elk, not given a specific name. And of course, the big thing, which everybody has feared, you know, BSE, bovine spongin encephalopathy. Remember in England when they found out that there were a couple cows that had it, they killed them all. So this is like something that theoretically could be transmissible to humans. I'm going to answer your question in a really funny way in a minute. Next one. So what is the one thing that all of those diseases share in common? The fact that it causes spongiform changes in the central nervous system. So when you look at a normal brain, we've looked at a lot of normal brains histologically. We see neurons, we see glial cells, we see white matter, gray matter. What if you saw little holes in the cells and in the spaces between the cells? It looks spongy. That's why they call it a spongiform encephalopathy. All prion diseases are spongiform encephalopathies, okay? And it's because a protein comes in contact with another protein, which is a normal protein, and it causes that normal protein to have a conformational change. Remember, that's the buzzword in biochemistry these days, conformational change. And as a result, that produces the disease. The main presentation, and certainly even in the ones that are like GSS, will eventually result in dementias. They will be fatal. There is no treatment for them. I'll answer your question now. I'll give you a specific example because it hits home in pathology. Whenever we heard in pathology that a patient died, we think of CJ disease, the pathologist would run away. We're not going to do autopsies because they thought, well, it could be highly infectious. The thought was maybe when we are sawing open the cranium and those little bone chips are flying around, even if they have nice gloves and everything, maybe one of those might slightly come in contact with the skin. And then the other fear, before we knew more about them, is that this could be something that could happen 20 or 30 years later. We didn't know what it was. Now we know a lot more about it, but the bottom line is you get another prion protein from, it's transmissible. This causes conformational changes in your normal proteins, and as a result, the disease occurs. It could be a long-standing disease. At first, they thought it was one of these latent viruses that could cause an infection 20 or 30 years later. But this is basically the mode of transmission. And once again, it's transmissible, it's fatal, and it has no therapy. Next one, please. There's a prion protein. It's normal. We all have prion proteins everywhere, especially in our brain. Well, when this prion protein comes in contact with an infected prion protein, it ultimately will result in changes which we call spongiform. We know where the protein is made. We know the exact amino acid sequence. We know exactly, what chromosome codes for it. But when it has its change, it's when it becomes pathologic. There's a very, very nice movie. I put the link on there. I don't think we're going to watch that movie today. We'll watch another movie today that's more important. But it's a professor from Harvard, a very, very good presentation, much clearer than what I could say, where he goes into what exactly happens. Next one. Okay, so this is like every other brain that we've seen. But do you see? It's a brain, but it's a spongy. Okay, Jose, I want you to put your pointer on at least 10 or 20 spongy holes right now. Okay, and first I want to ask you, how many neurons are in that picture there? Oh, 5 to 10, a million, one, about 5 to 10. Now, are these spongiform changes? Look very closely. You might not be able to see it from this lousy screen, but I can tell you the people that are online right now can see that even inside the neurons, there's spongiform changes, not just in the fibers between them. In fact, I think you could see it here. Why don't you point out, a couple of small spongiform changes in the neurons as well. I could probably see it better here. I'm going to take over control for a second. There's a few tiny little spongiform changes there. There's a couple there, but the majority of them you see are like between the neurons. And sometimes they can involve the glia as well. Next one. So that's CJ disease. About 1 in a million, just like the other one we talked about, GSS, that's also about 1 in a million approximately. It is not an epidemic. Okay, the great fear when you don't know about a disease is if you don't know exactly how it's being spread, you're extremely cautious. It does not run as an epidemic, sporadic cases. Some of the cases have been familial. We know it's transmitted from infected people. And it's once it kicks in, it's a rapidly progressive dementia, which means cortex, right? Gray matter, right? And also can move into other areas. We've seen some of those spongiform changes also, even in glia and in the cerebellum as well. But the main thing is a fatal dementia. Next one. Or are we done? Okay. The term demyelination we've used and thrown around a lot in the last couple of days, like it was a very nonspecific change. Poison the brain, kick the brain, shoot the brain, infect the brain. You're going to get demyelination. You can, just like that computer over there. It has wires, but those wires are nicely insulated and very nicely. So anything you could do to, traumatize that computer, probably traumatize the insulation before it gets to the wires. And that's like a good general example of demyelinating diseases. In the central nervous system, the generic term for demyelinating diseases is multiple sclerosis. Okay, multiple sclerosis has a few variants you should know that are listed as demyelinated, but technically aren't. So one of the big variants is something called acute disseminated encephalomyelitis. You'd think this would be a little more severe and a little more acute a variant. There's a demyelination there. Another one is acute necrotizing hemorrhagic encephalomyelitis. So you would think, besides seeing maybe gliosis and edema and demyelination, maybe you see some hemorrhage in there as well. These are more severe variants. They all have nice acronyms, which I bet I'll never remember except for this presentation. Now remember, demyelination is a normal reaction to any type of CNS injury. But the family of demyelinating diseases, specifically multiple sclerosis, is a primary demyelinating disease. It's not secondary to anything non-specific. It's a primary disease. Next one. Okay, so we had some nice presentation a few weeks ago. I don't know if you were there regarding, the relationship of vitamin D to MS and how people that get more sunlight get less MS and all this. For generations, there have been talks about what causes it. And it's always flipped back and forth from viral to autoimmune. And probably even from the presentation the other day, you'd have to think the ultimate cause is autoimmune. And because myelin is the target, you would think that probably some type of autoimmune reaction against myelin is present. It's generally a disease of females. It has a very high incidence of 1 in 1,000. That's a pretty high incidence, isn't it? Compared to CJD, which is, 1 in a million. The primary lesion of the area of autoimmune attack against the myelin in the central nervous system has always been called a plaque. Do not get that confused with the plaque of Alzheimer's disease, which is something completely different. What is a plaque? A plaque is an area of specific demyelination. So you would probably guess that MS is a disease of white matter where there's a lot of myelin rather than gray matter. Sometimes that's a very important differentiation on MRI. The classical clinical presentation, when you get your question on MS, it's going to be a relatively younger woman, comes in. Technically, any type of central nervous system, focal thing, but usually it's scotoma, blind spots, visual problems in a young woman. Perhaps that almost always they present that way. If you're to ask a neurologist, the last 20 MS patients that walked into his office where he made a primary diagnosis, he's going to give you a story of something like that. The disease can last for many, many years, exacerbations, remissions. There's all kinds of therapy, intrathecal steroids and interferons and basically gamma interferon, I think, is the main thing now. You probably have to check your farm for that. But I can't help telling you another story. My aunt had it, and she got it when she was very young. And she had severe exacerbations. She would say it would take her sometimes 2 hours just to get out of bed, and it would be like extremely painful every single day. And everybody thought, poor Aunt Eleanor, she's probably going to die first out of all of us, because my mom had, 6 kids in her family. Well, she died last. And Many of those years were good years with relative remissions as well. Next one. Okay. Before we had MRI, we knew there were probably focal lesions due to MS, but we couldn't really see them well. CT was not good enough. Now think about it. Now you have a method where you can not only look at the density of protons, MRI, but how they react when they're subjected to various magnetic or electronic impulses. In other words, remember we said that just about all demyelination, no matter what it's due to, is also associated with edema and probably gliosis. So even if you're not an expert radiologist and you're just looking at those brain slices, let me ask you two questions. There's a lot of white dots there. And can I ask you the question number one? Are the white dots almost exclusively in the white matter? Yes. Okay. And secondly, do you think the white dots are because of demyelinization, or do you think it's because they're related to edema as well? So yeah, when there's demyelinization, there's some amount of edema, and you could create, when there's a lot of edema, there's a lot of water. Where there's a lot of water, there's a lot of protons, because it isn't like water, 2/3 proton, as opposed to some of these other chemicals, and they can be seen very nicely. And they look like they're largely periventricular on the top. They're a little asymmetrical on the bottom, but that's a classical appearance. I don't know about that midline sagittal view. I don't see many areas that look like they're much whiter than the rest. I have a feeling that's probably not a T2 weighted image, which emphasizes water. It's probably what they might call a T1 or a proton density, where you're seeing actually areas that are less signal intense than the surrounding tissues. Next one. Okay, now there's a nice slice of a brain, not with the MRI scan, but with the pathologist knife. It's a whole mount. Those are great things to do. And in addition, that myelin is mostly fat. So if you were to look at white matter, it would be basically washed out. But if you could do a stain for fat, I think this one is called Luxol Blue, but there's a whole bunch of other ones. Some are red. This Luxol Blue stain stains fat preferentially to aqueous type areas. And I don't think I have to go there with a pointer. I think you could see that there are areas in that white matter. See, the gray matter is pink, the white matter is blue, that are asymmetrically white, which means loss of fat, which means loss of myelin. Jose, I want you to point out the 3 or 4 biggest ones. There's one that really sticks out like a sore thumb. That's a relative area. Oh, I see like a really big area too. In fact, you want to know something? There's one that's really spectacular. And, oh yeah, can I show you? Look at this one right here. This is not part of the ventricle. This is a real big area of whitening, okay? But you can see, like you saw an area there, you see a nice area there. That's classical multiple sclerosis. Next one. Okay, there's a plaque, if you're lucky to see it from a brain cutting conference. And I think you'll see that in the white matter, there are areas that look less white. And furthermore, I would also like you to use your imagination a little bit. And if you look at the areas that are less white, can I convince you that probably also they may look a little more edematous as well? Well, that's what produces the plaque signal. So when MRI came around, in vogue, I would say probably in the 70s, it started to be big. Everybody that had MS was now going for their MRI scans, and they were seeing all these little white spots all over the place. Every tiny little thing. The beautiful thing about it is if they tried some kind of regimen to treat it, okay, or if they were in an exacerbation rather than a remission, they can actually follow the size and number of those plaques as well. Next one. You know I'm going to show you a plaque microscopically. You can see on our looks all blue stained in the northwest, there's an area that just looks demyelinated. Well, that's pretty cool, probably there. If I told you that almost all demyelinization is associated with edema and gliosis, I think I could convince you that these little inflammatory cells, perhaps microglia, would be a sign of a plaque as well. Let's see. I don't know. Probably there's some gliosis here too. But take a look at the picture on the bottom right. That is a stain for neurofibrils, axons, dendrites. That's one of those silver stains that we saw before. And I talked to a neuropathologist a few weeks ago. He gave a talk on demyelinating diseases. And what he stressed is that you can have an awful lot of damage to the insulation of the wires before the wire quits working. And do you remember also when we gave our presentation on neuropathies, you can see like a tremendous amount of demyelinization of the peripheral nerve before that nerve actually stops working. But once the axon is damaged, that's it. So let's just say you can do a sizable amount of damage to the insulation to these neuron wires before there's even clinical presentation of symptoms. And probably a woman that comes in, a young woman with her first presenting symptoms of eye problems, probably already has plaques. The first thing the doctor is going to do is MRI. Of course, if he's a neurologist, he's going to do an MRI on just about anybody that walks into his office, right? Another thing that I have a friend that's a neurologist. I like to tell these stories. His name is Dr. Hazelrig. He's an outstanding guy. And I said, Bob, what do you do if you're an excellent neurologist and the patient comes in and you do a really good exam and you say, okay, I read my books. I know on the basis of this patient's symptoms that there's a lesion in the periventricular frontal gray matter. And you find out that it's in the occipital white matter instead. I says, what do? Do you bite the bullet or just default, to the radiologist? He says, you basically have to default to it. So that's what all of these clinical things that you're learning, and you feel proud that you know how to diagnose this and that and do all these special tests. When you wind up doing a laboratory tests, x-ray tests on those patients, you're almost always going to default to your clinical judgment. And that's not a good thing, is it? But that winds up what happens very often in medicine. Next one. Okay. Let's talk about the classical degenerative diseases of the central nervous system now. But let's also look at it from an anatomic point of view, which you have to do. What is the central nervous system? Well, it's cortex, that's the highest level. Further on down, you have your brainstem and your basal ganglia, your corpus striata. That's another area. Then there's the cerebellum. And then finally, when you go down that spinal cord into the tracts, there's a motor neuron tracts. So when you think about the concept of central nervous system degeneration, think of those 4 areas. And not only should you think of those 4 areas, but you should think about the main buzzword associated with every one of those areas. Cortex, dementia. They lost their marbles. They're crazy. They don't recognize their own relatives in severe cases. You all know people that have it. Sometimes it seems like we can get a little bit this way ourselves at times. Basal ganglia, think Parkinsonism type symptoms. You all know what they are. We're going to review them quickly, and we're also maybe give you some references to classical things like cogwheel rigidity and pill rolling tremor and stuff like that. Next area, cerebellar. The primary diseases involving cerebellum almost all have the name ataxia in them. And we're going to look at a really nice movie. If we see only one 2-minute movie today, it's going to be a movie of a renowned professor on YouTube demonstrating what an ataxia is. Because a lot of these terms that we use, you know, we think in general, somebody with ataxia can't walk right. But there's a specific type of routine that they go through to really be sure this is ataxia, you know, rather than, you know, drunkenness or, you know, a pebble in your shoe or something like that. Finally, everybody knows what muscle atrophy is. So when you get primary diseases of either upper or lower motor neurons, you're going to be talking about muscles that are atrophic. Next one. Okay, cortex, that's our first stop. The primary degenerative disease of cortex, in which dementia is the ultimate symptom, is Alzheimer's disease. It's much more common than all those other diseases, except for the last one, which is MID, multiple infarct dementia. People that has a lot of little strokes due to any reason can be demented as well if those involve cortical areas as well. Now there's a few other primary cortical degenerative diseases besides Alzheimer's. We're probably going to mention them briefly. One of them is called frontotemporal degenerative disease. You could think of that as Alzheimer's. You know, Alzheimer's, all areas of the cortex are involved: occipital, parietal, you know, frontal, temporal. But in frontotemporal, you could think of it as Alzheimer's that primarily involves the frontal and temporal area. Nevertheless, it's a separate disease. There's also a PIC disease, degeneration of cortex, which is primarily frontal. Maybe we'll say a quick word about that, maybe not. Another disease that involves more than just cortex was called progressive supranuclear palsy, and also a cortical basal degeneration. I put little brief descriptions of them underneath there, but let's go into the big one. So this is how you have to think of it. Somebody comes in, I hate to be disrespectful, but for lack of a better word, they're demented. You know, they lost their marbles. So what's the first thing you think of? Okay, Alzheimer's. What's the second thing you're going to think of? Multi-infarct dementia. Okay, so I don't know what the exact statistics are, but let's say 75% are Alzheimer's. Most of the rest of the 20 are multiple infarct dementias, and all the other ones are just a couple percent. So the rest of these are pretty rare, which is why we're not going to spend much time on them. Next one. Okay, Alzheimer's disease. It's sporadic. It could, you know, generally run in families. They're not a specific gene, but you know that if you use the multiple gene concept or the soil theory, you know, if a lot of people in your family had it, you know, your chances are good even if you don't have it. There is no one specific gene. It's cortical gray matter. It's atrophy. Okay, it's atrophy of cortical gray matter. Cortex would be from anywhere in the brain. And the two things you have to remember from the point of view of pathology, I'll try to make this very simple, are the neuritic plaques and neurofibrillary tangles. Now, remember when we talked about multiple sclerosis, we said a plaque was an area of demyelination? Well, a neuritic plaque now in Alzheimer's is a whole different kind of plaque, but they still call them plaques. The neuritic plaques are big. They're more than the size of one neuron. You know, there could be the size of, you know, area-wise of 10 neurons. The tangles are within a neuron. So those are the two things, and they all have specific reasons why they're there. If you want to think of Alzheimer's disease as a disease in which you have a buildup of amyloid in the cortex, you could think of that, although it's not real regular amyloid like you have with amyloidosis and you know, from plasmacytomas and stuff like that. It's a different type of amyloid chemically. It's called beta amyloid, but it still stains like amyloid does. You can do the Congo red, and it's red, and then you polarize it, and then it's apple green. So let's look at some more aspects of these plaques and tangles. Well, let's look at the brain first. That's probably the world's most normal brain. Maybe you have a couple of those lying around in pickle jars in the anatomy lab here. Do you remember when we showed you the picture last session on cerebral edema? We said that the sulci were almost absent because the gyri were edematous and these valleys were now almost non-existent. Well, cortical atrophy is the opposite. Now the sulci are prominent. Why? Because there is loss of cortical substance rather than edema, where there's an increase in cortical substance because it's wet. Next one. Oh, go back. Before you do, get a good feel for the depth of those valleys, which of course we call sulci. Get a good feel right now and then flip to the next slide. Are the valleys bigger? They're bigger grossly. They're also bigger on CT. They're also bigger on MRI. And let me ask another question. Do you think if this cortical substance is basically shrinking and the gyri look bigger, do you think, relatively speaking, the ventricles would look larger too? Yeah, they do. This is all classical cerebral atrophy, cerebral cortical atrophy. Next one. I would like to say that if you go to the classical occipital, temporal, frontal, parietal, those are all equally small, large valleys. Next one. There is a plaque, and let me explain, and there is a tangle, and let me explain a little bit about each one now. A neuritic plaque is a cluster of nerve fibers, hence the term neuritic, and it's very often surrounding a substance which winds up being largely beta amyloid. Sometimes, if you don't do the stain to look for some of these tangles, you just may see it as a little pink area. Remember, the plaques are big. The tangles are solely smaller within individual neurons. Here is a neurofibrillary tangle. It doesn't really look very tangled, does it? It just looks like maybe there's some accumulation of substance in that neuron, and very often it even, in some extreme cases, is big enough to displace the nucleus a little bit more off to the side. There's a stain for probably microtubules, within their neuron, and you could see that, if you looked real close on electron microscopy, it might look a little bit tangled. So let's make this very simple. The plaques are amyloid. The tangles are phosphorylated microtubules, very often causing them to precipitate and even displace the nucleus. Let's go to the next one. Okay, there's a plaque. You can see the general area is much larger than an individual cell or two. And if you were really smart and you go, well, let's say that there may be a little bit of amyloid in there, but we don't have to do that crazy Congo red stain, which, the tech screws up every time anyway. Let's get a stain against a specific antigen of beta amyloid, an immunohistochemical stain. Then, of course, look at, if you have a hard time finding those plaques with regular microscopy, like you might see here, take a look at all of this beta amyloid immunostain that you see here. So it's even in areas that look relatively normal. So Alzheimer's disease is for everything that it is or isn't, one of the things it definitely is accumulation of beta amyloid. Next one. Okay. There are more plaques here. You see these neuritic plaques, and you see something in the middle of the plaque, and it doesn't really look like a cell, but it looks like some kind of proteinaceous substance. So you know that that is a beta amyloid. If you were smart, you would do either immunochemical stain to confirm it, or perhaps if it was big enough, it would just light up very nicely on Congo red. Now, this thing also says plaques and tangles. This is primarily a plaque here. But if you look, let's say, this one does not show the tangles too well. But I would like to direct your attention perhaps to this part of a neuron here. Do you see how it's kind of, oh, and that's not the best example. Probably some of these things probably are neurons that have it as well, but they don't, you can't really prove it's a neuron because you can't really see the nucleus. So let's just call this a plaque. Next one. Okay, here's a plaque, and you finally did your Congo red stain. And of course, it's not as good as even the H&E, but you see that there's something red on Congo red, so maybe it's amyloid. And then you don't do anything. Whoops. Somehow I dragged that guy up. You don't do anything to that slide except polarize it. Put a polarizing lens on each side and turn it 90 degrees until you get a nice, brilliant apple green birefringence. That's a plaque. That's beta amyloid. Next one. Now let's see a really good example of a tangle now. You know there's 5 or 6 neurons in this picture, and you can see some of them look a little bit fat, and you can see that some of them looks like the nucleus in neuron is being a little displaced over here, and the cytoplasm of the neuron is not uniform. So let's do a stain for microtubules. Next one. And look at, you could see that there's a lot of stuff that's being precipitated or collected. And I think I have another picture here that shows the nucleus actually being displaced by this phosphorylated microtubules. Next one. There you go. There's a nucleus. There's your tangle, phosphorylated microtubules, and there it goes. It even looks like it's getting to the accumulating or precipitating where it's even displacing the nucleus. Okay, so much for the histology of Alzheimer's disease. Next one. Okay. The other cortical dementias besides Alzheimer's basically have one thing in common. They're frequently also called tauopathies. Okay? So you remember those other things that we mentioned, the rare ones, the other types of cortical dementias, you know, like frontotemporal, pick disease, PSP, and CBD. What do they all share in common? The fact that they're all dementias and they're rare and they're not Alzheimer's is the fact that they have an accumulation of tau protein. Aha. And tau protein is also a hyperphosphorylated thing due to a defect in the tau gene. So wait a minute now, doesn't that kind of go back to Alzheimer's again? Weren't we seeing in the tangles also hyperphosphorylated tubules? So that's the connection. So if you want to call Alzheimer's disease a tauopathy as well, you can, but remember, it also has the amyloid. Okay? So it's still very, very unclear how these relate to the other ones, and I'm not going to go into them. But I am going to go into the thing now, which is much, much more common than the other degenerations, and it's called MID, multiple infarct dementia or vascular dementia. Next one. Okay. Do you remember when we were talking about hypertensive encephalopathy? We're saying especially in the area of the basal ganglia, but technically anywhere. You can get small infarcts in the brain, which are called lacunar infarcts or slit hemorrhages. It's very, very common when you cut the brain of a healthy person that, dies of a car accident, that you will see tiny little infarcts. Very much so is like, if you do an autopsy on somebody that died of cancer or whatever, you invariably might see little infarcts in the heart. The same thing is true with the brain. There are probably 90% of the people that have small infarcts of the heart or of the brain are walking around totally healthy, totally functional, and they never knew they had anything. If, however, the infarcts are either numerous or large. And what's the cause? What's the cause of any infarct? Atherosclerosis, hypertension. Then they can become demented just from the fact that they have had numerous strokes. Perhaps small strokes, but numerous ones. Let's see the next one. Oh, this is great. If I had a chance to give you a devilishly hard exam question, I would probably do something like this. I'd probably throw that up, and I'd probably say, is that MS or is that MID? And you'd say, well, hell, that's not a fair question. But remember, we told you that in MS, the edematous areas are strictly limited to the white matter, or we'll say primarily related to the white matter. In this one, you can see, yeah, a bunch of little, what you might call plaques from MS, but do they also involve the cortical areas as well? Yeah, so this is classical MID. It's pretty extensive. This is something that could produce a dementia. Next one. Okay, let's move down now from the cortex into the basal ganglia. There's something called Parkinson's disease, and there are variants of Parkinson's disease, and there are many diseases that produce Parkinson-like symptoms. But just like we said that demyelinization was a generic word for multiple sclerosis, we can also say that diseases of basal ganglia might be another generic word for Parkinson's disease. But I would rather use the word Parkinsonism, because clinical diseases of the basal ganglia is Parkinsonism, whether it's pure Parkinson's disease or something else. So there's also something called multiple system atrophy. There's also something called Huntington's disease. Perhaps you might have heard of it as Huntington's chorea. It's a familial genetic disease in which there's a severe disappearance or very limited amount of basal ganglia, and for that reason the ventricles look very, very large. But the symptom of basal ganglia and brainstem diseases is called Parkinsonism. So what is Parkinsonism? Next one. Okay, we're not going to do movies on this one. We'll probably do a movie on ataxia. But I bet you that everybody here has heard the word cogwheel rigidity. That's probably the thing that you remember the most. Sometimes pin rolling tremor or intention tremor or a festinating gait. I shouldn't, these are recorded, so I probably shouldn't say this, but we had a professor that was very, very, very good professor. He was an old guy, just like me. We did our residencies together, and students loved him. But he had a lot of Parkinsonism-like syndrome. So I would frequently see him, in the hallway like this. Would he had a diminished facial expression too? Yeah, a little bit. What I'm trying to say is that Parkinsonism-like diseases, primarily basal ganglia, don't necessarily involve cortex. That guy was as sharp as ever, okay? Thank God. And also, my mentor in medical school, who recently passed away at a wonderful age of mid-90s, he had Parkinsonism for many years too, and I went to visit him last year, and he was as smart as he ever was, which is 10 times smarter than me. Do you know what cogwheel rigidity is? Does anybody know? Well, do you know what a cogwheel is? A cogwheel is like one of those little ratchets inside your watch. So do you notice how it moves like this? So something that has cogwheel rigidity doesn't move slowly. It moves like that. Or pin rolling tremor. Looks like they're rolling a pill. Or what's another? And probably the single biggest symptom, and I urge you to look at this, some of these movies, is intention tremor. It seems like it's always at the first thing on the list. I'll try to give an example of it, although, I'm not a clinician and I'm not even a good actor, but let's say that I just want to shake Mario's hand for being a good engineer. Well, my hand is not tremor, okay? And it's not tremoring when it's moving, but when I intentionally go to do something, that's intention tremor. If it was tremoring all the time, that's not intention tremor. So these are all symptoms. These are the CCPPs. These are the things that you're going to get on your exams, and you have to know some of these buzzwords and what they look like. Thank God they can't put movies on your exams. You can't show this in a picture. Is that these are going to be the way people present with diseases of basal ganglia and brainstem. And this is generally what we call Parkinsonism. One of the causes of Parkinsonism is Parkinson's disease. Another disease is called multiple system atrophy. Another separate entity, post-encephalitic Parkinsonism, or those types of symptoms of the basal ganglia after a bout of encephalitis due to, we said a whole wide variety of things. And of course, remember we mentioned also when we talked about the frontal things, there's a little bit of overlap here from the cortical into progressive supranuclear palsy, cortical basal degeneration. These are cortical disorders that also have Parkinson's disease. Now, let's get down to the pathology. This is going to be the easiest thing of all. When you took your anatomy last year, did you slice a brain at some point in time? Okay. Well, do you remember when you sliced your brain? I don't know, not with a knife, not with the MRI or CT scan. Remember you're taking your coronal slices and you got into this area called the midbrain? Remember it has a little hole in it that connects the third to the fourth ventricle called the cerebral aqueduct. Do you remember that there was a black substance in that midbrain, which, let's see, what would be a good name for that? How about if we call it substantia nigra? Do you also remember when you cut through your pons, there was another area that looked just as black, and it was called substantia nigra also. And the area of in the sections near the pons was called the locus coeruleus. So those are the two areas of the brain that are rich in dopamine. And dopamine, as you remember, it's in the melanin pathway. So even in the brain, it looks very dark. So when you cut through the midbrain, you saw those dark little bands called the substantia nigra. And you cut through the pons, you saw the substantia nigra. Well, what if I told you, you already know that Parkinson's disease is a disease in which there is not enough dopamine or dopa. So probably when you cut through it, it doesn't look quite as black as it should. Next slide, please. So what is the primary gross and microscopic pathologic finding? As well, we'll get to a few other things as well. It's loss or pallor of the substantia nigra. And I must also tell you there is something called Lewy bodies as well. So when you hear Lewy, think Parkinsonism type diseases. Next one. So there you go. I really know, I'm not making fun of you. I know that you instantly recognize this as midbrain. I just know it. And one way you know it is that they got that nice little black bands down there. Well, what if you cut through somebody that had severe Parkinson's disease and those black bands really were not there or not very black? Next one. Bingo. Normal patient on the left. Parkinson's, normal patient on the right. Parkinson's on the left. You see, there's loss, there's pallor of the substantia nigra. Next one. There's the locus coeruleus. I know you recognize that as pons as well. Take a look on the right side. Also some more substantia nigra. Take a look on the left. It's hardly there at all. I don't know. I'm a big freak on spelling. I thought, my God, is it really spelled Coeruleus? So I Googled both the variants, one without the O and the other with the O. And actually the one with the O looks like it's about 4 times more common than the shorter version. Next one. So as long as we saw that there's a loss of pigmentation or loss of substantia nigra. Maybe microscopically there's loss too. So yeah, so this would be a question I would ask if they turned me loose. I would say, which one is the normal patient? Which is the one with Parkinson's disease? Next one. Well, the one with Parkinson's is the one that. Now here's another body. Next one. And I would like to tell you it's specific and diagnostic, but of course it isn't. You find the other things. This is a protein. It's called alpha-synuclein. You could stain it specifically for it. And these are little eosinophilic inclusion bodies that you get. And if you want to call those diagnostic of Parkinson's disease, you can, but of course you see them in a few other diseases, so practically nothing is diagnostic. There it is. That's the protein, alpha-synuclein. Next one. We're going to see it in some other diseases as well. We talked about the classical symptoms. I put the two most common buzzwords on there. It's progressive, and think about it. Remember we said that it's generally it's not related to cortical type disease, but it can be. Because it's progressive, it ultimately can be. So it can produce a type of dementia as well, or hallucinations, very, very severe, very, very late stages. And the beautiful thing about it, for which somebody got a Nobel Prize. Let's go back. I got to show you this. If you don't mind the cogwheel rigidity in my lecture, go back a couple things. Yeah, right there, right there. Let's say that, you're in the middle part of last century and, you got a microscope and, you've already seen a lot of brains and you go, all these patients with Parkinson's disease here don't look like they have enough black substance. Oh, the black substance is dopa. Maybe we should, that's very logical, maybe we should give these patients, dopamine or dopa. And you can't because it doesn't cross the blood-brain barrier. But then you realize that there's a way you could modify it by creating a little L isomer called L-dopa. It goes in there. So these patients generally are going to have tremendous responses. Remember they made a movie about it with Robin Williams? I forget the name of the movie. But this is the kind of simple, clear thinking that inspires Nobel Prizes. Nobody ever won a Nobel Prize because they were a champion at following regulations, okay? Next one. Next. There we go. Let's go to Huntington's disease as well. I don't know where we are. Did you skip too much? I think you did. Yeah, okay, go to the next one, Jose. And we have to, in all honesty, mention that there is another Parkinsonism-like disease called multiple system atrophy, or MSA. It's a whole wide spectrum of diseases. And even though it's not Parkinson's disease, it has Parkinsonism-like symptoms. Why? Because it's a disease of basal ganglia. And also has a lot of autonomic dysfunction as well. And lo and behold, it is also very rich in those alpha-synuclein bodies. But remember, in the case of MSA, they're actually in the oligodendrocytes. I think I have a picture of that. Next one. Yeah, take a look at that little inset here. You know that these are primarily oligodendrocytes, right? In fact, most of these are because they have little halos around them. But do you see that not only do they have halo around them, which is myelin, but they also has something that's stained with the stain that's specific for alpha-synuclein. So, that comes up again as well, doesn't it? Next one. Huntington's disease. I don't think I have to tell you that it was also called Huntington's chorea. Everybody called it that a few generations ago. Now they want to call it Huntington's disease. And I don't think, if I told you that these ventricles are dilated, one of the reasons the ventricles are dilated is because there's almost no basal ganglia there at all. Remember, the basal ganglia are basically the borders, the inferior borders to those ventricles. The reason why these look like that because there's basically no substance. So it's a genetic disease. It's rare, and it results in severe atrophy of the basal ganglia. You know, the three components, or if you just don't really want to call them corpus striata, you can. And it's a familial disease. It results in chorea. We also talked about Sydenham's chorea when we talked about rheumatoid arthritis, rheumatic fever, I mean. And it's kind of a snake-like motion. I'm not very good at that, but I would also recommend you at some point in time just do a quick, 30-second Google of Huntington's chorea and just watch people doing it. And severe atrophy of the corpus striatum. In other words, basal ganglia. Next one. Okay. Let's move down to the ataxias now. When you hear ataxia, think cerebellum. There is a disease of the cerebellum, a degenerative. It's called spinocerebellar ataxias. There's classical Friedreich's ataxia. And there's another ataxia, also a cerebellar degenerative disease, which is more of an immune disease and is also associated with telangiectasias, or dilated blood vessels in various parts of the body. And if you want to Google all these things, you can, but most of the pictures that you see will be in the eye. Those are dilated little blood vessels in the corner of the eye, and somebody with ataxia telangiectasia. I think it's critically important to know exactly what ataxia is. So with all of the movies that I had access to, I'm going to show you one, and I think it might be the next one. Okay, here's what I want you to do. Or maybe I'll do it. I want you to bear with me, and I'm going to show you a nice ataxia. By the way, has anybody here actually seen ataxia? You don't have to be afraid to raise your hand. You might not see many of them. Most of you, it looks like you haven't seen ataxias. So I'm going to do a copy on this, and then I'm going to open up a browser. And let's see if it's going to work. Cross your fingers. I don't think we'll hear it, but we'll see it. Oh.
The ataxic gait, the patient has difficulty narrowing the station to maintain balance. So typically they'll have a wide stance trying to maintain balance, and there will be unsteadiness in the trunk. Truncal pitchability, which is an anterior-posterior femur about 3/3. And there's also a tendency to lunge or to jerk sideways, and the patient then has to catch himself. Of course, one of the ways to bring out this particular type of problem is to narrow the station, asking the patient to walk tandem. So if I then am ataxic, and then try to walk tandem, then I'm going to have difficulty walking.
Classical. I don't think the buzzards are getting this, but you certainly got it, and you got this sound as well. He's a doctor, but he's also a very good actor. I really think that was good. Let's see if we could somehow get rid of this now. Okay. So what about if we talk about the spinocerebellar degenerations now? We know that they're all associated with ataxia. It's described here as loss of extremity muscle coordination, but you got like a really, really good example of it on the movie. And spasticity as well. Now, can they also involve neuropathies? Of course they can, because that cerebellum is connecting to nerves in the spinal cord. Next one. You know what? I think this is a good time to take a little bit of a break. I don't know what time it is, but I feel like we've been here for about an hour. I think we could probably finish this up maybe in another hour or a little bit more. So let's take our 10-minute break. If Mario wants to show some nice pictures here, he can. We know that if we don't touch that thing for 10 minutes, often it freezes. So let's hear some nice music, too.
Turn to you as you are softly sleeping. Think of what I'd like to do. You are somewhere dreaming. I feel so happy by your side. Oh, I wonder why. Find it hard to find the words to say what I am feeling. So in love, I'm so alive. I know you're the reason why I'm so happy all the time. Oh, I wonder why. I need nothing else in life than to
What happened?
Breaking it off and setting it off in the big way, making the girls them chill their mind, making them have a good time. Yeah man, SPZ, alongside Riri. Come down now Rihanna, take it to them girl.
Work it up, boy, 'cause it got me feeling naughty. I wanna know, boy, if I can see you shawty.
Most definitely.
Set it up, boy, make me hot all over my body.
Break it off, take it off, don't mistake it off. Yo.
Work it up, boy, 'cause it got me feeling naughty. I wanna know, boy, if I can see you shawty.
Yo.
Set it up, boy, make me hot all over my body. Break it up tonight.
Yo, juggle and feel what you feel all the while that you want a good man to give her the style. Wild child, so she dey on my file. It's a long time now, me want flow the style. Flow the style, my car run like the Nile. Of the most energy me want give her tonight. Give her tonight and make she feel right. Make she fly like a kite and reach a new high scar. We give it to the girl, them make them reel up and ball and make them start call. Anytime she wants it back, she have to call. Don't she fall? I'm hitting it on the spot and now the race starts. Penetrate so great, cause she feel it so up and down. What you think say?
Work it up,
Immediate if not
got
before.
me feeling naughty. I wanna know, boy, if I can see you shawty.
Boom back.
Set it up, boy, make me hot all over my body.
Break it off, take it off, don't mistake it off. Yo.
Break it up, boy, 'cause it got me feeling naughty. I wanna know, boy, if I can see you shawty.
Yo.
Set it up, boy, make
Yo.
me hot all over my body.
Free
Break
me,
it up
SPZ.
tonight.
Yo, no doubt. Y'all, you shoulda know SP and a scout, naughty sweat and out, make your ball out. Shout, make you all happy, me give affection in your direction. We go all out. Y'all, just follow me if you love energy. If you want pedigree, cruise like Penelope. Because you just bounce with the dirty. We keep giving you the Q to the U to the A, yeah. To the L to the I to the T to the Y. Girl, I got to try. Take your booty, make you reach to the SKY. Woman, I got to say, the way you move is making me eyes. Girl, cause you know, say your S to the E to the X to the Y. Boom, bang, boom, bang.
Break it up, boy, 'cause it got me feeling naughty. I wanna know, boy, if I can see you shawty. Set
Sexiness.
it up, boy, make me hot all over my body.
Check it
Break
out.
it
No
up
doubt.
tonight. Break it up, boy, 'cause it got me feeling naughty. I wanna know, boy, if I can see you shawty.
Yes, up on the
Set
brain,
it
no
up,
shit, stop.
boy, make me hot all over my body. Break it up
Yes.
tonight. Boy,
Uh-huh.
the way you push up on me, I get rough is what's done to your life.
Eh,
For sure, we're gonna break it up
Yo.
tonight.
Yo, come in, circle.
Oh boy, you really shouldn't waste no time.
Sing it.
Come let me back up on your dance hall step.
Bring it.
And I'm hoping, baby, you don't mind, 'cause I really wanna break it up tonight.
Instantaneous.
Break it up, boy, 'cause it got me feeling naughty. I wanna know, boy, if I can see you shawty. Set it up, boy, make me hot all over my body. Break it up
baby girl. Yo, give it up, give it up. Hey now.
Break it up, boy, 'cause it got me feeling naughty. I wanna know, boy, if I can see you shawty. Set it up, boy.
Quando sono sola sogno all'orizzonte mancano le parole. Sì, lo so che luce la stanza quando manca il sole. Se non ci sei tu con me sì. Le finestre mostra tutto il mio cuore che è acceso. Chiudi dentro me la luce che hai incontrato per strada. Time to
quando sei lontana sogno all'orizzonte mancano le parole e io sì lo so che sei con me, tu mia luna, tu sei qui con me, mio sole, tu sei qui con me, con me, con me, con me. Time to say goodbye. Paesi che non ho mai veduto vissuto con te. Adesso vivrò con te. Partirò. Su navi per mari che io lo so, non esistono più, con te io vivrò, con te partirò. Su navi per mari che io lo so,
I guess playing that song by Andrea Bocelli and Sarah Brightman, Time to Say Goodbye, was kind of appropriate because this is our last sync session here. But I also thought, because this is our not only the last session, but the last hour, if they decided to kick me out of the school now, this would be a good time because I'm all done. So that's why I brought Woofy, to protect me. He also might be the reason why I'm kicked out. Woofy was born in St. Lucia, and he used to come into our classrooms over there, and he would make the rounds. He would make sure every single student got a chance to pet him. I don't know whether he's going to do that now because he has to go up there, but he's going to hang out with us for this last hour on brain tumors. Can we close everything down? And we'll start up. We got a little bit more, then we'll talk about brain tumors. This is Woofy, by the way. He's going to be the proctor for the exam. If you have a bone in your pocket, he will allow you to cheat. If you have about $500 in your pocket, I'll allow you to cheat. Okay, we're going to talk about a few last remaining portions. Remember, we talked about the concepts of cortical degeneration. We talked about the concepts of basal ganglia, brainstem degeneration, generally called Parkinsonism. And we talked about the concepts of cerebellar and cerebellar tract degeneration, basically called ataxias. And now we're going to talk about motor neuron disease. And just like we all had a big generic word to cover degenerations of motor neurons disease, the general catch-all word here is ALS, amyotrophic lateral sclerosis. And it's very appropriately named because it's amyotrophic. The muscles degenerate. When neurons degenerate, when motor neurons degenerate, upper, especially lower, the muscles do too. So it's an appropriate name. Probably the best name for it is devoted to one of the greatest New York Yankees of all time, Lou Gehrig, who died of it, and now it was very often called Lou Gehrig's disease. I've attended some lectures by a man by the name of Stephen Hawking over in Cambridge, who also has a disease. You've probably seen some of his lectures, and it doesn't look like he's talking. He's basically sitting there in a chair, and some of the stuff he said is just so profound. So I think that if there was a question about whether lower motor neuron disease affects brain function, I think you know the answer to that. Even with advanced ALS, Stephen Hawking is still smarter than all of us, put together. We'll also mention that there's a few other motor neuron degenerative diseases, which you could read on your own. X-linked bulbospinal atrophy, also called Kennedy syndrome. And we talked about spinal muscle atrophy when we talked about muscle diseases over in El Yunque. So we're not going to mention that again. Let's go on to the next one. But there was something else I wanted to say. Good boy, Woofy. That's what I wanted to say. Nobody knows what causes ALS. We all know it's a disease of motor neurons, upper, lower. And if you want to go back to the CCPP, it always starts out, it's more common in men, starts out in muscle wasting, and it routinely starts out peripherally, muscles, small muscles, the extremity fingers. All of a sudden you see, more exaggerated spaces between the fingers, and you can start to see, your metacarpals a little bit better. Some cases of it are familial. And of course, I know a few people that had it. It's progressive. As the muscle wasting, as the muscle atrophy, approaches things like diaphragm, you could probably guess what happens there. Or in one case, my nuclear medicine chief tech had a mother who had it, and she died because she had problems with swallowing. If you have problems with swallowing, you're going to get infections and so forth. So that's basically the CCPP of the disease. And remember, they're always going to present you something, maybe a picture of a hand of a guy that comes in, you see muscle atrophy in the hand. Next one. There's Lou Gehrig. Even without having immortalized the disease, he probably was the greatest Yankee of all time. And of course, Stephen Hawking. I don't know if you've attended any of his lectures, but I'll tell you, if you've ever thought you knew generally what the universe is like, or try to imagine it, you have no idea how much of a concept. Who would have ever thought, even when we were kids, that there's something called a black hole? Well, this guy just sat down and thought. He really didn't have much else to do because he can't play baseball, and he thought of the concept from physics that there must be something called a black hole. It's only been in the past few years that somehow, don't ask me how, he was absolutely right. Next one. Yeah.
One of the major reasons for euthanasia in Europe, right? I mean, one of the major, I guess, cases that go towards the suicide programs that they have there. Is that correct?
I don't know.
I think I remember you saying.
But if you say so, I'll believe you. Did everybody hear what he said?
I don't know. That's what I was asking.
Okay. There's a spinal cord. You could see some of the lateral columns, hence the term lateral. You can see some demyelination. Now we know this is not a demyelinating disease per se, but there's demyelination because there's nonspecific injury. You could see the cortical spinal tracts. They're kind of outlined, and you can see how they look like they're the ones that may be involved. They're the ones that are involved in this. But you can also see down here in the anterior horn, okay, or ventral horn, to see that you have neurons, and not only are the neurons vacuolated, but the tissue around it as well. So that's a degenerative disease of anterior horn cells or lower motor neurons. Next one. I'm going to just talk about in general some concepts now. I'm not going to go into them. I would probably urge you at some point in time to just Google some of these things and look for the CCPP. When we talked, well, we didn't talk, and I didn't do the chapter here on genetics, but when you take this whole big category of lysosomal and storage diseases because of genetic usually autosomal recessive, lack in enzymes, and therefore the substrates build up. Well, we talked about they could build up in liver, they could build up in heart, but they can also build up in brain too. So if you want to think of the so-called lysosomal and storage diseases, the whole family of them, which also involve neurons, which there's a large number of, that would be the first category of genetic metabolic diseases. The thing I will go into in a little bit more detail are the so-called leukodystrophies. Leukodystrophies is a generic term for a whole family of specific leukodystrophies, which are the result of abnormal myelin formation because of various enzymes needed to make the myelin are genetically absent. And I'm going to throw a whole bunch of words at you. And I remember when I was in medical school, they talked about each one of these for about 20 minutes, and I thought I was going to jump out the window. But let's categorize the so-called leukodystrophies as being genetic problems in myelin synthesis, not demyelinization, but the inability to make proper myelin. And then you should know, just like we had the mitochondrial myopathies due to a whole wide family of defects in mitochondrial enzymes in muscle, there's a whole big category of that for neurons as well. Let's say a little bit more about the leukodystrophies, because I know some of these are relatively household words. Crab is a word, is a type. It's usually at the top of the list. The so-called metachromatic leukodystrophies is another category. These are all have their own separate little CCPP, and I'm not going to put you through the agony of trying to differentiate it. The adrenal leukodystrophies. Here's the one that you'll never forget. Pelizaeus-Merzbacher, okay? And then there's another one called Canavan. So what do all of these things have in common? They have in common that they are genetic defects in the proper production of myelin. These are the leukodystrophies. And a leuko stands for white, right? And myelin is white matter. And dystrophy means it's not being made properly. Next one. Okay, before we get into tumors, I think we should rattle off a little list here of some of the common things that are regarded as acquired and toxic to the central nervous system. They're all important, and everybody knows. We actually, in the chapter on nutritional diseases, we go through about half of it is on alcohol. So you know that regular old alcohol, CH3, ethanol, basically has devastating effects. Some of them are very acute in a syndrome that's called Wernicke-Korsakoff, but it's not the alcohol itself that does it. It's due to the fact that the alcoholics are also vitamin deficient for B enzymes. So Wernicke-Korsakoff is a disease of vitamin B1 deficiency, but it's almost exclusively in alcoholics. You know that a severe vitamin B12 deficiency, in which you can lose good portions of your functional posterior columns, and therefore deficiency in vibratory sense, which is why you all carry around your tuning forks, is another example of an acquired toxic disease. Finally, diabetes. We spent a lot about diabetes. We talked about diabetic neuropathies. There's a whole family of CNS diseases related to diabetes that probably, if you really want to be very, very practical about it, probably the number one disease of diabetics that involves the central nervous system is strokes, okay? Because of their severe small vessel and large vessel disease. Here's another interesting thing, carbon monoxide, okay? What if I was to say to you, if I cut off your oxygen supply of your brain right now, or your entire body, which are the first cells in your brain that would die? In other words, which are the most sensitive to oxygen? Well, probably the ones that are the most sensitive to oxygen or loss of it are the ones that have the highest demand for it, like the Purkinje cells, and also in the hippocampus. When we hear that a person has died of anoxia, the neuropathologist will always, make sure they take a lot of sections through the hippocampus to make sure that there are not early changes there. Methanol, do you remember in the old days? Of course you don't remember. Alcoholics that ran out of booze, so they wind up drinking methanol. They became blind. Well, basically it pickles the retinal ganglion cells. The brain itself is the single most resistant organ to acute radiation effects. Remember we said the small lymphocyte was the most sensitive? Well, probably the least sensitive is a neuron. So patients generally can tolerate an extreme amount of, radiation to the brain. Why? Because we said that radiation sensitivity is related to the turnover of the native cells. So things like lymphocytes and GI mucosa and high turnover areas are very sensitive to radiation, whereas cells that never multiply, like mature neurons and mature skeletal muscle cells, are the least sensitive. Nevertheless, how can I phrase this? There are some reported cases of people that worked like in cyclotrons, and there were accidents, and they actually had a massive amount of radiation exposure, whole body, including brain. So it produces an extreme central nervous system effect as well. Finally, chemotherapy is toxic to everything. The brain is not no exception to it, but when a person is getting both radiation to the brain as well as chemotherapy, it enhances the effect. So it makes the brain, which is normally very, very resistant to radiation, more susceptible if it's in combination with chemotherapy. They enhance each other. I think we're done. Now I'm going to show you a couple pictures of one of these things. Do you remember the mammillary bodies? Could you recognize those instantly? Well, what would happen if all of a sudden they looked kind of hemorrhagic? Those are the classical findings for, Wernicke-Korsakoff. And even though they're two separate syndromes, they basically combine them one now, with Korsakoff, I believe, being the most severe one. So somebody that is extremely deficient in vitamin B1, and they're an alcoholic, and they come in, with severe central nervous system effects, or if you could limit effects to the mammillary bodies, this is what they would look like. There's a cross section over there. Jose, you want to find the hemorrhage in the mammillary bodies on the coronal section? There you go. They're on both sides, aren't they? So it's a symmetrical disease. I don't know if the one external thing has it or not. They look like pretty normal mammillary bodies to me. Let's see. I'll slide it down a little bit. Yeah, they look like they're pretty normal here. Next one. And last one, before we get to brain tumors, is the loss of a vibratory sense in vitamin B12 deficiency, a disease called subacute combined degeneration due to demyelinization of the posterior columns and lateral due to vitamin B12 deficiency. Sometimes the very, very earliest way to pick this up, somebody like that is going to have a lot more symptoms, is that the first thing to go is their vibratory sense. So if you're wondering why they make you include one of these tuning forks in your little black bag, that's the reason. Next one. Okay, we're into the last category, central nervous system tumors. We're going to do this one without a lab. We're going to have a general discussion, and then we're going to say goodbye. It wouldn't be fair if we didn't have a good general discussion on central nervous system tumors. So let's do a quick little overview of them. First of all, most brain tumors are not of neurons. Most brain tumors are cells that support the neurons. Most run-of-the-mill brain tumors are what they call gliomas, okay, tumors of glial cells. And even though there's a variety of glial cells, most of them are astrocytoma. So the word astrocytoma is almost synonymous with the word glioma. Now, because pathologists love to classify everything, from, 1, 2, 3, 4, if you took a glioma that was so well differentiated, it looked a little bit like normal brain, maybe a few generally increasing glial cells. If it looked like it normal on CT, if you couldn't find anything on MRI, and you can't even find anything when you cut the brain, and sometimes even microscopically, you'll have a very, very hard time differentiating a low-grade glioma from this thing that we call gliosis, which is common in any type of brain injury. Of course, if it has a mass effect, then it's easy to do. But a small, low-grade glioma is almost always missed in every possible way, even in terms of clinical symptoms. Most people that come in with symptoms of brain tumors already have demonstrable lesions on CT or MRI or, certainly a good neurologic exam as well. Okay, so if you realize that astrocytomas are gliomas, but you don't want to neglect the other glial cells, there are tumors of oligodendrocytes called oligodendrogliomas. And as you know, oligodendrocytes are the chief myelinating cell, so they all have a little halo around them. What if I was to tell you that the oligodendrocyte tumors cells probably also have a little halo around them? That's how you know that it's an oligo. Same thing with an ependymal cell. We all knew that ependymal cells look like epithelial cells. So if you had an ependymoma, would it look like a glandular cell? Yeah. If you saw an ependymoma of the brain, you might say, is this a metastatic adenocarcinoma? Of course, if it's limited to the choroid plexus, you don't have to worry if it's metastatic or not, right? Next thing are the actual tumors of the neurons themselves. Mature neurons don't give rise to tumors because they can't multiply, but these cells that give rise to the neurons can. So there are a relatively small number of brain tumors are actually from neurons, like the neuroblastoma or the medulloblastoma. The thing to remember about a medulloblastoma, it's always in a kid, and it's always in the midline of the cerebellum. That's all you have to know about medulloblastoma, no matter what they might throw at you on a picture. And then, of course, we can't neglect the meninges. Technically, they're not glia, they're not nerves, but the meninges can give rise to tumors also. They're called meningiomas. They're almost always benign, and of course, if you look at some of these big classifications, you're going to see some of them are not benign. Most of them are benign. They're all firm. And the one thing you should remember about a meningioma, it's very, very firm. It can be locally invasive. And they almost always have the consistency of a super ball. So every time you get a meningioma in the pathology lab, you just feel like bouncing it on the floor. Lymphomas. Lymphomas of the brain were practically non-existent, primary lymphomas of the brain. Now, do you remember when we looked at the histology of the brain? We didn't say there are normally lymphocytes, did we? We said they could have lymphocytic cuffing when you have the encephalitis. But you have glial cells. The glial cells, the microglia especially, they kind of are the lymphocytes of the central. So primary lymphomas of the brain are very, very rare. But guess what? Now that we have this disease called AIDS, it's without a doubt the most common primary malignancy of the brain in an AIDS patient. So before AIDS, we never saw lymphomas. Now that we have AIDS, every primary tumor of the brain is probably a lymphoma. And the rule is a space-occupying lesion of the brain in an AIDS patient is either going to be a lymphoma or a tumor which is really inflammatory. They call it toxoplasmoma. Finally, Metastatic disease to the brain can occur in just about any type of primary. But I will tell you another statistic you might want to remember. If your patient comes in and he has symptoms of some kind of central nervous system disease and you do a CT scan and you see one big or just one lesion in the brain, what are the chances that it's a primary brain tumor versus metastatic? It's about 50-50, isn't it? But if it is metastatic, what is the most likely place that it came from, without a doubt? The lung. Thank you. Next one. So that's the overview. Now let's talk about the CCPP. I don't think this is a big surprise. Headache, vomiting. I don't want to be, run over this too quickly, but these are classical presentations: patient headache, vomiting, mental changes. But technically, any localizing CNS lesion can be the result of a brain tumor. So I don't want to leave that door, too far open. And of course, it could result, because of the expansion of the tumor, as increased intracranial pressure as well. Also, increased pressure when you do your spinal tap, so-called opening pressure, elevated. CNS tumor can produce any localizing CNS abnormality. Next one. So what do? You take a history, you take a physical, you do a really, really good neurologic exam. Most likely you're going to do a lumbar puncture. Most likely that patient's going to go to CT or much more better, MRI. They both have some places just don't have MRI. You may resort to an angiography if you see a localized lesion to look at its blood supply. Generally speaking, the more vascular it is, no matter what it is, if it's a primary brain tumor, the more likely it is to grow faster, okay? And finally, you may do a biopsy, and that's where the pathologists come in. This is what I often would get up for in the middle of the night. Neurosurgeons wanting me to take a little piece of the brain that they sucked out and look at under a microscope and, tell them hopefully at least whether it's a primary tumor or metastatic or some funny stroke. Because, they all look sort of, white, right, on MRI. But usually if they're going in to do a biopsy, they already know it's a neoplasm. Next one. So some of the features of brain tumors, microscopically and grossly. First of all, is benign or malignant? Isn't that the primary question? Is it something that is a primary tumor versus a met? And remember, a single space-occupying lesion of the brain can go either way. It's about 50-50. What is the location of it? Very often, when I get back to Dr. Hazelrig again, very often they are very good at giving the location of the lesion based on the patient's symptoms. But when they look at the MRI or the CT, they often have to tremendously readjust their way of thinking. Age of the patient, that brain tumors are very, very often tumors of younger people, just like the leukemias, just like a lot of the bone tumors. You look at on CT, look at the X-ray density. Does it have a lot of calcium? Is it basically not have calcium? Certain tumors, for example, like the oligodendrogliomas, they have an abundant amount of calcium in them, even if they're benign. Vascularity. This may require an angiogram to determine that. Certainly can be seen also when you do the biopsy of the tumor itself. Is there necrosis present? And of course in the brain, the pattern of necrosis is classically what we call liquefactive necrosis. The brain turns to soup, okay? So do you think that a malignant primary brain tumor would be more likely to be necrotic than a benign primary brain tumor? Absolutely. In fact, it's the main criteria. When you look at your various gliomas or astrocytomas and you decide whether you want to call it 1 or 2 or 3 or the worst one of 4, which is also called the GBM or glioblastoma multiforme, the main characteristic, there's a few other ones, but the main one is necrosis. And finally, is there compression of neighbors? As a rule, as a good solid rule with very few exceptions, primary brain tumors do not metastasize. Well, that might not be too comforting if the brain tumor just happens to be only, 1 centimeter big and it's near a cardiorespiratory control center, okay? So I don't think that knowledge that a brain tumor doesn't metastasize is necessarily a good thing. Next one, edema. And of course, remember, we mentioned edema, but edema is going to be like anything. You could have a small brain tumor the size of a pea, but it could producing enough edema to make it look like it's the size of a walnut. Next one. I think, another thing to remember is that when you are dealing with a primary brain tumor, and remember, most of them are gliomas or astrocytomas, if they're low grade from the point of view of the pathology, you might want to say, is this just a local area of gliosis secondary to some nonspecific injury? Gliosis is nonspecific, just a demyelinization edema, or is it part of a low-grade glioma? That could be extremely difficult, and there's no use to try to tell you how to differentiate them, because even people that have been looking at them like me their whole life still often shudder when we think of having to differentiate one versus the other on microscopy alone. Does it involve gray matter or white matter? What is the texture like? If it's necrotic, it's more likely to be soft. If it's calcified, it's more likely to be hard. If it's a meningioma, you could bounce it against the wall a few times. Is it vascular? Vascularity also being a big criteria for malignancy. So something that's a glioma that's very vascular and very necrotic, you probably don't need a microscope to diagnose it as a high-grade glioma or glioblastoma multiforme. Are there a lot of mitoses? That's sometimes a feature helpful in differentiating gliosis versus glioma. And of course, the usual things like pleomorphism, hyperchromasia, the words you always see on your pathology reports for tumors, calcifications, cysts, satellite lesions. If it's a malignant tumor, it may have another little satellite lesion next to it. If it's metastatic tumor and there's another lesion, most likely the lesion is going to be somewhere else throughout the brain. And finally, probably the main thing, which we go back to on day one when we talk about cancer, is delineation. Invasiveness is the #1 word that differentiates benign from malignant tumors anywhere, not just in the brain. Next one. Okay, I'm just going to throw this one at you quickly to show you some of the nightmares that I have. I think you can say that there's a collection of cells in most of the East Coast there, stretching all the way to the Rocky Mountains. That looks like there's an increased number of glial type cells. And, they don't look, it's not necrotic, they don't look terribly bizarre and large. So that's the consideration now in gliosis versus low-grade glioma. It could go either way, and there is no answer to this. I could probably ask for your opinions and the buzzards' opinions, and then I could give my opinion. But it's a nightmare. Next one. Okay. In all honesty, if you looked at this, you could say, well, it still looks like brain tissue, but I do see an increased number of glial-looking cells. And to be quite honest, some of those glial cells look just a little bit bigger and darker. So this might still be a difficult case, but this happens to be an intermediate grade glioma. So in a low grade glioma, like a 1 or a 2, you would see almost totally normal looking glial cells. In a 2 or a 3, you might see a little bit more of an atypical cell here and there, but there's no necrosis and there's no bizarre cells either. And there's no extreme hypervascularity. Next one. Okay, this is high grade. What are the things in this one that we didn't see in the other one? Well, first of all, the cells are bigger Some of them are darker, and you can see necrosis. And Jose, I want you to show me a little area of necrosis. I can't see your pointer. Is it there? Yeah, there you go. That's exactly what I had in mind. Can I also ask you, so you got necrosis, you have large dark cells. Can I also tell you something else too? Remember we used the word palisading? We're talking about basal cell carcinomas of the skin. We used the word palisading. We talked about fibroblasts in a rheumatoid nodule. Do you think that some of these tumor cells are kind of palisading as well? Yeah, you see, extending out northwest from that area. They're kind of like lined up. Do we have another one? I probably got something really nasty there now at the next picture. Yeah. Look at that's really necrotic. And I think we could summarize this whole thing by saying the three, we'll make it three. I could say four, but let's say three. The three main features of a high-grade glioma, if you want to call it a Roman numeral 3 or a Roman numeral 4, or if you want to call it what everybody else calls it, a GBM, or glioblastoma multiforme, is necrosis and palisading and extreme pleomorphism. And I know why you're raising your hand, because you're going to say, well, isn't perivascular growth also a feature? Yes, it is. But I told you I was going to limit it to three.
I was actually just going to ask, is that red splotch there, would that be a vessel?
I would say it looks to me like it's an area of necrosis in which there is blood. I would not really call it a vessel simply because I don't really see a intact vessel. It could have been. So those are the three things, or if you're really smart, you got room, you could remember the fourth one. Next one. Okay. Let's talk about another feature. Let's talk about central necrosis. Remember we showed you that brain abscess the other day? We said, well, it looks like the center is liquefied and the external part has a little capsule. Well, very often, even the radiologist will look at something like this if it's one lesion, and they'll say, gee, I don't really know if this is a tumor or if this is just an abscess. Well, in a way, functionally, it's really both, isn't it? Because if you have a high-grade tumor that is growing so fast and so vascular and outgrows this blood supply in the middle, it's going to look like a liquefied abscess on the middle. Another unfair question would be, take a look at the inside of that abscess, point to the dark area, Jose. And I'm going to ask you a question now. Is this a T2 weighted image? Probably not, because remember T2 enhances water. So this is probably a different type of image that is supposed to do something else. The brightest thing you always see on T1 weighted images is fat, and you certainly see a lot of fat in the scalp here as well. Next one. Okay, we're done with gliomas. We're done with astrocytomas. Let's talk about a couple of other types of glial cells that are not astrocytes, which you probably should have a vague recognition about. Maybe even we'll throw in a CCP as well. What are the non-astrocyte gliomas? Well, oligodendrogliomas and ependymomas. Could you have a microglioma as well? I never heard of one, but let's just limit it to those two. Next one. So what is that on the left? What kind of normal glial cell is that has the halo around it because it's fat and it's myelinating all the central nervous system white matter? Those are oligos, right? Next slide. What is that? Gee, they don't look like normal oligos. They look like they're bigger, darker, more of them, more denser. Those look like tuber cells. But guess what? They still have a little halo around them, don't they? So that's the tip-off that tells you that this is a oligodendroglioma. Next one. So there you go. Normal oligos on the left, oligodendroglioma right. It wouldn't be fair if I should also tell you that oligodendrogliomas also have you know, a lot of calcium in them too. They're usually very, very quite heavily calcified. When I went to China last year, we went through several of the pathology departments and met with the residents and went to their conferences. You know, one of the residents said, "Oh, Dr. Minarcik, can I show you this brain tumor case?" And I thought, oh my God, they're going to find out how stupid I am because I won't know the answer. So she showed me a slide, and it was a classical oligodendroglioma. And I says, "This is oligo. I think I recently gave the lecture in it." And then she opens up her Robbins textbook. It's in Chinese. And she goes, "Yeah, that's an oligo." Next one. Okay, so let's get a little bit on the CCP. You see all that heavy, hard stuff? That's calcium. Remember, the oligos can be very, very calcified. And it's a relatively rare one. It's only a couple % of all gliomas. CCP, think young people, okay? Not really, it can occur in children. Mostly it's, you know, 20s to 40s. And if you want to be really smart, in case somebody may be sadistic, it's associated with a 19 chromosome loss. Either the short arm or the long arm. Next one. I'm sorry, go back, that's wrong. It's either a loss of the short arm of chromosome 1 or the long arm of chromosome 19. Next one. What is that? I showed you this picture the other day. This is a normal lining of ependymal cells. You could see maybe it's in the central canal or maybe it's along a ventricle or something like that. You can see white matter adjacent to it. They look like they're only things in the brain that look like normal epithelial or glandular cells. They even have cilia. Next one. What is that? What if I told you that was a tumor of the brain? Well, I know the first thing you'd say is, well, it's probably a metastatic adenoma because I can see all those glands. What if I told you this was a primary tumor of the ventricle? That gives it away, doesn't it? This is an ependymoma. Next one. There's the normal ependymal cell lining on the left. There's a glandular ependymoma on the right. Next one. And you want to do a little bit on CCP of the ependymomas. Well, it's also pretty rare. Where would it most likely occur? Well, a tumor of the ependyma would most likely occur in areas where there is a lot of ependyma, like a choroid plexus, okay, like the ventricles. So could they cause hydrocephalus? Of course they can. And this is also in children, a little bit older group than the other one. There's a childhood peak and a peak at 34. And do you remember when we talked about hydrocephalus in general? We said that almost all hydrocephalus is due to the inability to reabsorb CSF rather than producing too much of it. Well, what if a ependymoma was well differentiated enough to still be pretty functional and make CSF? That's the only example I could think of as a hydrocephalus due to increased production of CSF rather than decreased reabsorption. Next one. Aha. I don't know. We looked at some neuroblastomas and we talked about the ENT because it can occur in the optic. We talked about neuroblastomas because it's one of the most common solid tumor of kids. But you can also have a neuroblastoma of the brain. And yeah, they are neural cells, but they are primitive neural cells. And you all know that when you hear the word neuroblastoma, what's the instantly comes to your mind? Rosette. Or Homer Wright rosettes if you want to give somebody credit. So Jose, I want you to find me 2 or 3, maybe 4 really good rosettes. There you go. There's one. There's another. There's one. So how would you describe a rosette? Well, it's a bunch of primitive-looking cells sitting around an area where there's like around a round table in which there's just a cytoplasmic mass. Those are pretty good rosettes. So you know, if they showed you this picture and you knew what a rosette was, you would know this was a neuroblastoma. Next one. Aha. That thing there looks like there's something near the cerebellum. It looks very much like it's in the midline. It looks like it's a tumor. So is this an adult or a child? Question number one. You know it's a child. And number two, give me the histologic diagnosis of this tumor. Forget about taking the slides. Just tell me what it is. It's a medulloblastoma. Medulloblastoma, midline cerebellum, kids. Next one. I'm really young kids. There's another midline tumor of the cerebellum. You could tell it's either partly necrotic or maybe vascular. I don't know, but there's another midline sagittal view. Yeah. What's that? Well, let me see. Let me see. Why did I put that there? Might have been a mistake. Yeah, why don't you? I put that there, Jose, because I wanted you to zoom me. This sounds like my kind of humor. I saved, no. Zoom the little insect. See, the nice thing about PowerPoint is if you save it and you tell it to do the option of don't compress the pictures, then you can put like really big pictures in there and zoom it up. Now, here's the question. Does it look like a neuroblastoma without rosettes? That's because medulloblastomas are also tumor of neuron precursors as well. They look very similar. Next one. You could either unzoom him or just go to the next one. Next one. Okay. Without a doubt, the most common type of brain tumor, I don't know if it really should deserve the word brain tumor, is a meningioma. It occurs in the meninges. So if you remember when you dissected your brain and cut open your craniums and your cadavers, where were there a lot of meninges? Well, there's a lot of meninges parasagittally. There's a lot of meninges in that falx. There's a lot of meninges in the tentorium, separating the middle from the posterior cranial fossa. So wherever there's a lot of meninges is where meningiomas would occur. They're very vascular, even though they're firm. So if you do an angiogram or a nuclear medicine angiogram, they just light up very quickly like an AVM. A lot of blood vessels in them. And they're benign. Sometimes the neurosurgeons and even the regular surgeons, they get offended when you say they're all benign. Say, well, I had one guy tell me in Arizona, he goes, yeah, you pathologists will call these things benign, but I had one where it went through the meninges, it went through the skull, it went through the scalp, and if we didn't do something about it, probably would have went through his hat too. So yeah, they could be invasive, but they're usually benign. But then we said that most brain tumors don't metastasize in general. This is certainly no exception. Remember the Super Bowl? That's not a word you're going to find in Robbins or on your. That's my word, only because I can only think of two things in medicine and pathology that make me want to bounce them on the floor and pick them up. One's a meningioma, the other's a fibroadenoma of the breast. Both nice rubbery texture. The buzzword for meningioma is Samoma body as well. Let's go to the next picture. Maybe we'll see some Samoma bodies. No, but you do see a tumor there in the area where there is meninges. It's very heavily calcified. This is one of the things that very often is calcified. It looks like it even has pretty much the same, or in some areas even greater density than the bone. But you notice how it's limited to that one area. That could really, really, really be compressing that brain, but it will never invade the brain. Next one. There's your super ball. Look how it compresses the brain. Next one. And there, a meningioma is basically described, classical variants, as whorled fibrovascular cells with Samoma bodies. And I'm going to show you want to show that really nice calcified Samoma body in the middle there, Jose? And even though some of those other ones are not really calcified, they would probably be called Samoma bodies. The thing you should know is that the Samoma body of a meningioma is not the same as a Samoma body of a papillary carcinoma. In papillary carcinomas, whether they're thyroid or ovary or breast or anything that has a papillary adenocarcinoma, the Samoma bodies are dried up, shrivel up papillae, epithelial structures. In the Samoma bodies of meningiomas, they are just calcified, whorled, fibroblastic cells. Remember, the dura, isn't that basically fibroblasts? Next one. HIV, honorable mention here for a brain tumor. You could see AIDS patients that come in with space-occupying lesions. It's usually a differential diagnosis of toxoplasmoma versus CNS lymphoma. This one happens to be on the right. It's a lymphoma because I see like a lot of lymphocytes. If it's the same thing that I'm showing on the left, then remember the toxoplasmosis of the brain, besides causing a type of encephalitis, can also have a tumor-like effect as well, in which case they're called toxoplasmomas. Even though they're still infectious, they have kind of like a tumor name to them. Next one. What is the most likely tumor to metastasize to a brain? Without a doubt, lung. So if I made a list of the last metastatic brain cases I had, probably the first 7 would be lung. You know, breast often goes quickly. Melanoma can go anywhere quickly. GI, kidney, but lung is always at the top of the list. Next one. Okay, we're into the home stretch now, and I'm feeling kind of emotional, but it wouldn't be fair if we didn't discuss 2 other little things. And when we talked about neoplasms before, of course I didn't talk about them with you, only the iguanas. We talked about the concept of a paraneoplastic syndrome, which in many cases were tumors making endocrine-like substances to produce endocrine-type symptoms, although the increase in hormones was related to the tumor cell and not the endocrine gland. People that have primary small cell carcinoma of the lung, without a doubt, are the most likely to have a paraneoplastic syndrome. I listed a few things on the right here, like Purkinje cell degeneration. Remember, those are the cells most demanding of oxygen. They're also the biggest cells when you look at them in the brain. Sometimes you can have an encephalitis type of picture, but not an infectious organism. It's because of a tumor, most likely small cell carcinoma. Sometimes you could have sensory neuron degeneration in the dorsal root ganglion, you know, perhaps something like herpes zoster, but it's secondary to a paraneoplastic syndrome. A nice little tip is that we talked about patients that come in with eye movement disorders. You know, my son should know this very well. You know, you could go through a variety of eye diseases and some of the things we talked about, like the autoimmune disease of the neuromuscular junctions, but they can also be due to patients with a primary malignancy, of which small cells are always at the top of the list. I mentioned lymphomas and breast cancer there as well, but the font is totally indicative of the frequency. It's usually small cell. Next one. And I believe this is the last one. And I threw this in because I know that you cannot have an exam where they don't ask you something about the familial CNS tumor syndromes. And we talked about this in greater detail in genetics, but I want you to remember that in neurofibromatosis 1, the classical neurofibromatosis, neurofibromas, you know, were the big tumor. They could be in the skin, they could be in peripheral nerves, they could be in the central nervous system, and also gliomas were part of the picture. But in neurofibromatosis 2, schwannomas you know, those nice little tumors of myelinated peripheral nerves. And meningiomas are also the hallmark features for neurofibromatosis too. It wouldn't be fair if I didn't mention a little bit about tuberous sclerosis. It's a disease in which you have what they call hamartomas or tubers distributed throughout the body, of which central nervous system is the main place. And another familial tumor syndrome called von Hippel-Lindau that's characterized by hemangioblastomas, a familial disease, chiefly within the cerebellum. We are done. It was a pleasure to hang out with you for these 4 months. I want to remind some of the late iguanas that the eye talk, which my son gives, will be available to everybody, and that we will not have time to do the review in which I incorporate the USMLE factoids with the PowerPoints, but I have selected those questions, and I will be working on them, and I will have Jennifer send them all to you. So it's been a lot of fun here, and thanks for, I don't want anybody to rat on us that Woofy was here today, but if they kicked me out, I'm leaving anyway, so it's been a joy teaching you.
On behalf of the entire class, we just want to express our gratitude for you coming out here and helping us with this, with pathology and showing us, how much we can learn, not just as a class, but as an entire world. I mean, being a part of this is wonderful, and your dedication and hard work has been an invaluable tool for us here at SJB. I really, really, truly appreciate it. So if you guys can join me in giving Dr. Minarcik a round of applause.
Woofy, come on. Thank you. I can't say anymore. You called it hard work, but it was massive fun. Believe me, massive fun. Hasta la vista.
One last thing. We wanted to invite you to just a small dinner tomorrow. Everyone is invited. So we're gonna send the plates out like on email or something like that. It'll probably be somewhere nearby, or we'll figure it out.
Okay.
Yeah.
Okay.
We got a pretty busy schedule tomorrow, but in the evening afterwards.
And I want some pictures, one with all the boys and the professor, and one with all the girls.
Okay. Great. Well, should we get the buzzards in there too somehow? The buzzards are still listening to us. They're wondering what's going on.
And you can sit here and all the guys first.
Can somebody stand in front of me so I don't look too fat?
Sit down and everybody.
This way? Should I sit down? Can I sit with Woofy? Come here, Woof. Come on, Woofy boy. Oh, good boy, Woof. All right.
He wants to be with the girls.
Come on, Woofy. You're famous, Woofy. Probably the buzzards wonder what's going on now. I'll just let them know if there's still a few around. We're taking class pictures. And Carolina, do you want to hold Woofy? Because Woofy loves you. There you go.
He's so cute.
Do you know what I like best about this photograph? The boy-girl ratio. Woofy.
I don't know if I have more. Maybe I don't have more.
I'll put the pictures on my Facebook, the boy pictures and the girl pictures. Just email.
Hurry, get in the picture. More girls.
Hurry!
More Rick.
I
Come
need
on,
more
come on.
girls. I don't have enough girls in my diet. All right. Thank you.
There's two boys here, Wolfie.
Oh, Woofy's a boy.
Can you put the timer here?
Veo la foto en Facebook.
Okay, I think we're still on the webinar. I don't know if any buzzards are still around. But I'll close it off with the song. Wait a minute. I got one more thing to say. We're done. But I usually save my very best song for the end of the school year. But it's going to be very hard for me to play this song because it was my wife's favorite song. And we're both from Chicago, so this is a good way to close off the session here. And the name of the song is very appropriately, "You're My Inspiration."
One more goes down, everybody, right there from this angle. One more. One more, right there, everybody. Timer, 10 seconds. No, that one, no.
Everywhere I go, always on my mind, in my heart, in my soul. Baby, you're the reason in my life. You're the inspiration. You bring feeling to my life. You're the inspiration. Wanna have you near me. I wanna have you near me. Say yeah. No one else needs more than I. We'll leave the rest to Chicago.
Yes.
When you love somebody, always on my mind. Well, the music is over and the festivities are over, so we'll just say, rock on your buzzards. We'll see you in a couple days without the iguanas. You want to close it off?
Yeah, so file and webinar.
Yeah, and then you have to click another box. Now you can turn off the thing that says stop.